What is the optimal treatment strategy for renal vascular hypertension with renal artery stenosis?
Well, I think the first thing is to give a good trial of medical therapy. Make sure that you really can't control the blood pressure on the appropriate medications. Most people think 2 or 3 drugs, maximal doses that make sense to be used together, like an angiotensin-converting enzyme inhibitor and a beta blocker, for example, or a diuretic. And if that doesn't work, and then you find somebody who has significant renal artery stenosis, that's the patient that you'd probably want to give a try to renal artery stenting in.
And would you tell us about the design and the current status of the CORAL trial, and what can we learn from the CORAL trial?
Sure. So the CORAL trial is a U.S. National Institutes of Health funded study. Took patients with high blood pressure and renal artery stenosis and compared 2 arms. One is a group that got best medical treatment alone. One is a group that got endovascular stenting and best medical treatment. The primary endpoint of this trial is a composite of major events like heart attack, cardiovascular-related death, the need for dialysis, stroke, things like that. The trial's done enrolling, is at the end of its follow-up period for the first year, and it's our hope that we'll get some data in this by the end of this year. Now, what can it teach us? Well, I suspect, although I have not yet seen any data, I suspect that we will identify patients in the CORAL trial who clearly were benefited by renal artery stenting. I also think we're going to find patients who were harmed by renal artery stenting, who would have done better had they been treated medically. So I think we will learn a lot. What we probably won't learn are what happens in the patients with really critical renal artery stenosis, patients with bilateral disease to a solitary kidney, because those people really weren't eligible to be in the trial. So I think we'll learn a lot, but I think a lot of questions will come out of the CORAL trial as well.
And in order to prevent rupture, we treat AAA with open surgical repair or endovascular therapy. And when can we treat the patient with medication instead of endovascular therapy for AAA patients?
Well, I think the decision about how to decide when to treat with an intervention for aneurysms is based on the size of the aneurysm. So if you find somebody who's got a large abdominal aortic aneurysm, or someone who under observation has had a rapid progression in size of the aneurysm, those are people that need to get fixed right away. Small aneurysms, particularly in patients who have no family members who've had an aneurysm, those are people who can be managed medically. The challenge is what medical therapy works. We really don't know. What we do know is that beta blockers probably don't slow the progression rate of aneurysm size. We think that tetracycline derivatives, antibiotics, actually have a role to play, not because of the antibiotic effects, but a side benefit of inhibiting matrix metalloproteinases, these substances in the walls of the aortic aneurysms that actually degrade collagen and elastin and make the aneurysm form. And then the last category of medicines that are used anyway, but may have some added benefit in aneurysms, are the statin agents. It appears that statins might in fact delay the progression of aneurysm sac size. In fact, in a study just released this month, looking at patients who had stent grafts for abdominal aortic aneurysms, those who took statins had a much faster rate of decline in size of the sac compared to those who weren't. So the real answer is, if it's a big aneurysm, fix it. If it's a rapidly progressive aneurysm, fix it. If it's a small, stable aneurysm, maybe tetracyclines, statins for sure, and then we'll have to see.
And please tell us your optimal treatment strategy for the asymptomatic patient with carotid artery disease.
So first, I think it's important to make sure that they're truly asymptomatic. Then determine if they have one of the high-risk categories. So do they have an anatomic finding that puts them at high risk? For example, a very high lesion above the angle of the jaw. A second procedure, so one that's already failed. Somebody who may in fact have radiation-induced carotid disease. Those would be high-risk people. Or someone who's got medical comorbidities like active angina, the need for a CABG, chronic kidney disease, bad obstructive lung disease. Once you've made those determinations, then the real decision is how severely stenotic is the asymptomatic carotid stenosis. Most people would agree that 80% or greater determines that they should have some procedure done. If it's less than 80% and they're asymptomatic, people probably will watch them with serial ultrasounds. And then, of course, the medical therapy is everything you would do for the cardiac patient. So antiplatelets, blood pressure control, aggressive cholesterol-lowering therapy, diabetes therapy if they have it, and smoking cessation.